Okay, so between Lee Burton and Chris Poirier, we're talking about what I'm going to speak about this year. This is a few months ago, and they wanted me to speak on this topic. And through my professional career, I've avoided this topic like the plague. I deal with it with my patients. I'm a physical therapist. I'm a board-certified orthopedic specialist. I do dry needling. I'll shine a class 4 laser on you. I'll crack your neck. I'll make your back make weird noises. I can do that. But since 1990, I've also been a strength conditioning coach. So as a young physical therapist, I sat there looking at people on my table saying, man, if I'd known you 2 weeks ago, we wouldn't be here. Now, unfortunately, we're here. I've got to be a PT. I've got to follow some rules. I've got to be efficient. I've got to have a plan of care, and I got to close this case. So you must be what your diagnosis says you are, right?
Okay.
Anybody in this room help somebody not be a type 2 diabetic here? Have you done that? Okay. And you don't do it by worrying about their insulin and how much you're giving them. You do it by all the other risk factors that could easily be managed with good advice from a coach, a trainer, a therapist, a chiropractor, an athletic trainer, a PE teacher. It's all the other stuff.
That's an area.
Healthcare does not care anymore. So quit asking them to and quit expecting them to. It's a friggin' business just like pharmaceuticals and shitty food. It's a business. So I'm going to talk about basically this topic. And I'm going to force you to consider 4 words because neck and back pain has touched you personally, or it's touching your clients and patients and athletes and you got to deal with it professionally, or both. Now, it's hard to see a blind spot. You get a new car, you're not familiar with it, it could have blind spots. How do you find out your car's got blind spots? Well, now we've got nice little alerts and the car damn near drives itself for you. But before we had that kind of assistance, you found out about a blind spot right after your next accident. How do you make a client, a patient, an athlete, or yourself aware of a blind spot? The only objective person in the room is the one that knows they're not, and they deal with systems and measurements to calibrate their self.
Good.
I'm not talented enough to not do movement screens. You know why?
I know.
If you're my client, you want me to guess at your exercises or know exactly where we're going to be in 4 weeks? I'm not talented enough to guess at movement screens. I speak to a lot of people who think they're that talented. They don't need them. I can watch them exercise, I'll know right what to do. But will you know what you missed? And will you know where your blind spot is? I am obsessed with going into every one of my cases, whether it's performance enhancement or rehabilitation, removing the blind spots. Because unfortunately, my career now, when I finally get somebody in my little clinic with neck and low back pain, I ain't the first one they've seen. But I got to see something nobody else did. I don't think I can dry needle better than the last person you saw, and I don't think I can crack your neck better than the person you saw 2 visits before that. I think I can control my confirmation bias better. I think I can get here clearer because I don't have an agenda. Some people are going to respond slow, some people are going to respond fast, and the diagnosis doesn't mean much if we don't run through these 3 words, philosophically speaking. I'm going to force you to do that. So if right now you're suffering with a little bit of back pain, neck pain, whatever, we're going to find your blind spots, because that's the part healthcare is not going to do. That's the part I need my trainers, my strength coaches, my athletic trainers doing. Because we could easily get low backs and necks better. I could see them once a week. You could handle the rest of the stuff. I could make more money if I'd see them more often, but I couldn't turn more cases, and I like doing that. I like closing cases. Awareness, protection, correction, development. The reason I avoid the topic on the internet and at conferences of neck and low back pain is because it's not a diagnosis, it's a symptom. So's type 2 diabetes. It's a completely preventable situation that rarely occurred in indigenous cultures and only occurs in Western cultures when we sell you stuff and tell you it's food and it's not. And we say it's okay to sit as much as you want to and not watch your risk factors. And pretty soon, you're in a place where you can't recover from it. We call that Western diseases. Back pain is managed pretty much the same way. But most people want to jump right to the correction. Literally, you want to see me get 1 million hits on the internet? Great Cook, favorite 4 back exercises, or favorite 4 exercises for low back pain. Okay? I've been interviewed by the magazines. I've been on the podcast. I won't say it. Now, I could easily, with a little bit of data, put you on the 4 that you need to be doing. And we could talk about everything you don't need to be doing. And we could talk about the self-screens you could do to stay aware of whether you're doing anything or not.
Yeah.
But most people want me to add a positive without removing a negative, right? I'd like to keep drinking a lot of bourbon and add some flaxseed to my diet. You think that'll make a difference? I think you'd make a bigger difference in your life if you cut back on the bourbon than if you added more flaxseed. But most people want to talk about the corrective, want to talk about the exercise, want to talk about the device, the protocol, the newest, latest, greatest way to fix you. But is it the latest, greatest way to balance you? Because people with imbalances are coming to us saying, help me achieve a goal, but don't confront my imbalances. What do you think the movement screen is? I'm not going to make your squat stronger if you can't squat well. That's what the whole well often thing means. You want to know how much, how big, how fast can we go? I'm like, how well can you do it first? Because I can measure well, we can grow often, but if we compound those things that aren't well, we don't get to do anything that often. So, most common code for low back pain. So literally, this is accepted. You walk into your doctor's office and say, my friggin' low back hurts. And they say back to you, you have low back pain. You're like, well, I just told you that. Yes, but now it's official. And I'm going to assign a code to it. And if it continues, you're going to get 3 epidurals, maybe some physical therapy, and if you still got back pain after 3 epidurals and an MRI, we can cut on your back for no reason at all. We'll find something, don't worry. That is the path you go down if you make it all about your low back pain and not the bag of rocks of risk factors you're carrying around all day long and not willing to confront them. And some data and some slides are probably going to startle you and confront you a little bit. So this is not a test today in intellect at all. Every one of you is smart enough to screen somebody and do it well. Do you have the courage to do something different Monday? Because I guarantee you, every one of you is going to find out, just like I did, if you run your decisions through a little bit better sifter, you won't feel like you're living on a conveyor belt, and you won't feel like you're putting somebody else on one either. Since 1990 to 2015, 54% increase low back pain and neck pain, spine pain altogether. People see this. I hear them on podcasts. Yes, the country's got weak cores. We just need more core training. You'll blow them up. Take somebody who's got a hot neck or low back and do what you're thinking core training is, and you're going to compound the situation. You're going to make them worse. They're already breathing shallow. They're planking their way through life. They have poor shoulder and hip mobility. Strengthening their abs does not unburden their spine. They can just lift more with a bad back. That's what core training does for people with spine pain. You think you're fit? You might be fit, but if you're still in pain, you have musculoskeletal risk factors. And you might be lean, but if you still got high insulin, you still got type 2 diabetes. Something else is causing it. Your sleep deprivation, your dehydration, your shallow breathing, your acidic diet. Okay? It would be way more convenient if we could just get everybody lean and fit and they wouldn't have pain, but we see just as much low back and neck pain in our fittest people than we do in our most deconditioned people. So stop using fitness as a vaccination for this. You can get fit while you got pain and probably do more than somebody who's not fit. But your story ends just like theirs do. With making every decision in your life revolve around those things that trigger pain in your back or neck and doing less and less of them until you're not here. That's how that ends. So I listened to all of the stuff about core training, which is way more than abdominal training. Core training considers what are your hips doing and what are your shoulders doing, causing your core not to do what it's supposed to do. See, a lot of times, what we see as weakness isn't weakness. It's inhibition. When a joint is in poor alignment, when a knee is valgus, when a spine has scoliosis, or when your head is about a foot out in front of your body, you don't manage loads well. As a matter of fact, your body has an automatic governor that says, hey, you're in bad position, unload the tension a bit. You want an example of that? Take a striking bag and I punch it. Now tape my wrist into flexion and ask me to punch it as hard as I can. I might be dumb enough to attempt it, but it won't be 100%. I can't. My lower brain is smart enough to say, you don't want to hit anything with a wrist that bent. It's going to hurt you more than it's going to hurt the thing. So our body is always going to dampen down the amount of available strength we have if we're not bringing integrity to our posture, good patterns to our function, good alignment to our spine. Oh, we'll get through it. We'll muscle through it. We'll sell you a knee brace. We'll sell you a back brace. We'll show you how to supplemental train a rotator cuff that's just going to tear again because you don't have enough torso rotation. It ain't that your rotator cuff wasn't strong enough. It's that you have to exploit it just to make the turn. How do we find out all these blind spots that people commonly have? Because I can tell you what we're going to do for low back pain. We're going to go with a low-grade medication, a high-grade medication, 3 epidurals, and a surgery. You've got the same proprioceptive awareness, same flexibility, and the same friggin' habits that caused your back to be painful in the first place. All we did was snip on a disc for a minute and a half. The deep muscles are where everybody gets it wrong. You didn't learn about them in school, and they don't respond to 3 sets of 10 or 10 sets of 3. It's not those kind of muscles. People see us working in the movement screen and down on the floor, working with people rolling and crawling and some of those developmental patterns. That's how you light those spinal muscles back up. Because once they've shut down, you can't come up with exercises that activate them. They've already decided to shut down. They're reflex-driven muscles. They're not frontal lobe-driven muscles. So coaching, conditioning of the deep muscles is futile. Removing the burdens that causes them not to fire like they should is brilliant. People want to talk about movement patterns, but if I'm restoring a movement pattern, where do I start working on your lunge? I can work on your lunge flat on your back. Ever heard of the bretzel? Yeah. Trying to lunge perfectly on a movement screen, enjoying an unbelievably tight bretzel is not what we've ever done. Some people, we got to reclaim that flexibility before we can get stable. Some people, we got to get stable before the flexibility shows through naturally. We don't have enough feedback loops to know if our clients are actually moving better and coming out of pain or not. Adding those feedback loops is exactly what a chef does compared to a line cook. A line cook assumes that everything that comes off their griddle tastes good every day, all the time. And some of you started writing programs like that. It's an infallible program. I've been using it for 10 years. It works on people that look like you. We're doing it. And that's fine. But a chef tastes everything that happens all the way down the line. They sample test. They look at balance. They look at flexibility. They look at indicators that these deep spinal muscles are coming back. And those are the risk factors I'm talking about, and we're going to learn a little bit about today. Altered motor control means even if you send the right signal, doing the right exercise in front of the right trainer, the output is not going to be what you think it is. Okay? If this is the depth of your squat, if that is as deep as you can squat, and if that is as much as you can get to your toes, what can I whisper in your ear that's going to make that change? Then don't coach dysfunctional patterns. Let them become available. There's a reason they're not there. They're not stable enough in this position, or they're not mobile enough in this position. If you lower the position, put me flat on my back and I can tuck right into a squat, it's not a mobility problem, because I got enough mobility to squat. I don't have enough mobility to balance posture and squat when I'm on my feet. That's what FMS has been doing for years. We see people, they look tight, they're not. They look flexible, but they can't use it. Screening puts you in just enough positions where we know what not to do, what to protect you from, but also to what to do. That calibration word I'm talking about is really what brings these deep muscles back. And so we can't just think exercise anymore. When half your clients are showing up with issues, but you can't just assume they got weak and you need to strengthen them, because that would have already worked by now. What are some things that can destroy your motor control, no matter how much grit you got, how good equipment there is, and how good your trainer is? Pain will negatively distort motor control. It's a poor learning environment. It's inconsistent and unpredictable in the responses, and it fluctuates every day. That's a horrible thing to train around if you don't have to. I'm not talking muscle soreness, because that usually dissipates in about 10 minutes of warm-up. Joint pain gets worse in about 10 minutes of warm-up, okay? Mobility and stability problems negatively alter motor control. This is all straight from the research. So if you're trying to get somebody out of low back pain and hoping their core and posture get better in the process, you got to look at which one of these could be driving it in the background, because this is way bigger poison in the system than exercise is good unburdening the system. So I'm a big fan of exercise, but I'm a bigger fan of movement. I don't have to do what exercise says. I got to do what movement asks me to do. Exercise programs and protocols are built around comfort, convenience, communication, and equipment. So we can put people in packages. The same thing you hate that healthcare does to you, that's exactly what we're doing to athletics and fitness. If I could put you in a little category, then I could manage you better, and I wouldn't have to pay attention to you as much. I wouldn't have to read your nuanced signals and realize that some people respond fast to this program, some medium, and some slow. I've always used movement as the canary in the coal mine, and that's an old reference to back before we had these oxygen sensors down in mines. If we hit a gas pocket or something and we're getting ready to kill a lot of people, believe it or not, if the canary dies first, you can get out before you die. So movement, believe it or not, and the reason we're obsessed by finding one of those things in the movement screen you don't do well and watching the daily progress of that. So I do a movement screen on you. I don't have to do one tomorrow. But if you flung balance, I'm checking balance after our exercise tomorrow. Because if your exercise actually changed the way you balance, then it altered your motor control. And if it didn't change the way you balance, we still burnt calories. We still gained strength. We still trained a muscle group. You don't move any better. So I'm always looking for a couple of movement indicators, a canary in the coal mine. In the military, we can do really bad stuff to people, like make them not sleep for 36 hours and get them completely dehydrated for no reason other than their training and to see how they respond. Well, we got a chance to see what happens when we movement screen a group of people and then sleep deprive and dehydrate them. And usually their movement screen drops 3 or 4 points. What if I'm the dude that didn't do the first movement screen? I just did the second movement screen and saw you had a low movement screen and forgot to worry about your state of readiness. I'm getting ready to assign you a corrective for a toe touch that will easily be back if you get a good night's sleep and some electrolytes in your system. because these muscles do have to follow the commands of signals, and these signals are transmitted by those electrolytes. So you can live in a toxic environment and move very poorly, and exercise won't change a thing because your poor movement signature is due to inadequate recovery, not inadequate stress. The further you get to the tip of the spear in the military and the higher you go in the pros, the more you will see strength coaches obsess about recovery as much as stress. When we've got a sedentary office worker, we're all worried about how can I stress them? They sit all the time. They're unrecovered too. They're already maxed out. Their metabolism is at homeostasis, not doing anything, and being 30 pounds overweight. So pick your stress wisely, because guess what? Not only are they at metabolic risk if they don't lose this weight, they're already at musculoskeletal risk. That means with the same safe exercise program, they're probably going to have an orthopedic issue before they change their metabolism. Hate to dump that on you guys, but this musculoskeletal thing is only growing. We're putting total knees in 40-year-olds now. All right? I can't fix them all. Keep them off my table. But we got to do the right thing in the training, in the advice, in the blogs, in the way we manage people, and that is do not suggest exercise programs before you screen somebody, because people at high levels of MSK risk can totally benefit from exercise. But you better pick it wisely. They only got a limited amount of energy, and if you waste any of it on an exercise that's not improving their motor control, their fundamental movement patterns, they're not going to be on their feet long enough to change their metabolism. They're going to have an orthopedic episode. That means me and anti-inflammatories and a doctor and a dry needle and an MRI got to get involved. And that just slows down something that never needed to happen in the first place had we chosen to exercise them at their goals, but through their risk factors. Your goals mean a lot, but your risk factors mean more. That's my responsibility. If you want to see what I'm talking about with these calibrations, I put some flows up on the internet. Mobility, stability, basically 3 stations going through a couple of different postures and patterns, but what are the 4 words I put up at the beginning? I'm more concerned by somebody going through this every day, changing their awareness. What if I made everybody in this room either do a sun salutation or a Turkish get-up every day? You wouldn't just know how to do the move better 7 days from now. You would know more about your body. Because your sun salutation is going to be way easier stretching this hip maybe than that one. Your Turkish get-up is going to be a lot smoother coming off your right elbow than your left. And smoothing those 2 out where you no longer say I've got a bad side means the sun salutation and Turkish get-up have done their job. It was never about sets and reps. It was about mapping yourself from the ground to standing and knowing every piece of friction you got. And instead of grinding it away and foam rolling it out, breathe through it, slow down, get some integrity, and let your brain and body recalibrate the fact that you can't transition from half kneeling to tall kneeling. And that's a very important step when you're learning to walk the first time, because every one of you did it, and you did it good enough to get to the next level because every one of you walked in here, and nobody trained you, and nobody taught you, and nobody activated your glutes. You taught yourself how to friggin' walk. But if that opportunity due to low back pain is taken away from you, we start right at the source of pain and try to fix you instead of putting you on the ground and saying, earn your right to stand with integrity again. So when you look at floor-based stuff like yoga or DNS or any of these places that start you on the ground, learning how to move, good science that says we should have been doing that all along. Your core ain't sets and reps. Your core is how you use your spine in every possible posture, from laying flat on your back to getting to standing. And do you choose to exploit your spine or organize your spine? The golf swing is complicated and it can shred your back if you don't do it right. But the golf swing is something where you don't make decisions once you decide to swing the golf club. As a matter of fact, you can't change much once you start the swing process. Sort of a closed loop system. You got to do the swing. The ball will tell you if you did a good one or a bad one. Surfing's complex. You don't make a decision at the top of the wave and hold that decision in a vice of your mind to the bottom of the wave. You are constantly having to manage this dynamic situation. Everybody in the industry has always wanted me to just give you the map of how to fix a low back, like how to swing a golf club. Fixing a low back is surfing a wave. You make a decision, you ride it out, you got another decision. Make it, ride it out, make another decision, ride it out. Taste the food, move the plate down, taste the food, hold the plate back. We've lost that art, okay? If you want to do something better, have a faster sampling rate. How many of you set a program into play and really don't question it for a month? Motor control responds fast. Muscle hypertrophy responds slow. If you're trying to make somebody bigger, faster, stronger, that's the SAID principle, 4 to 6 weeks, we got to have tissue adaptation. I've made a career by bringing people on the stage that cannot touch their toes and start talking to me about their fascia lines and cupping and stuff like that. And I'm like, hold up a minute. Okay, there you go. Now you're touching your toes. We didn't have to have those conversations because you wanted to make the reason you couldn't touch your toes 100% about tissue. And I just proved the tissue got you there. We regulated your tone. I showed you what to do with your low back, what to do with your hamstrings, what to do with your breath, and what to do with your center of gravity, and all of a sudden, you're not pressing the gas and brake. You touched your toes elegantly and authentically the way you were meant to, not in this weird pattern that you've adopted because you haven't recalibrated yourself. So many of us go straight into conditioning the problem, assuming this is a 100% tissue problem, when really, how many of us right now know you'd get a better night's sleep if you got a massage 30 minutes before you went to sleep? Put your hands up, be honest, don't you anybody lie to me right here. Okay, that's never gonna happen. I don't even care if somebody loves you. That's never gonna happen. You're never gonna get a massage before you go to bed. But what you're really saying is, I'm carrying extra tension to bed, otherwise the massage wouldn't make a difference. Can you stretch it out? Anybody ever thought about stretching before bed? Because if you don't carry that tension to bed, you may sleep better. If you sleep better, you may not wake up with such a bad HRV. Your state of readiness is a little bit better. You can do another stretching session. Before you know it, you can wash that tone off of you. 50% of most of the people I see are carrying a lot of tone and tension. I'm not going to assume that's your movement screen. I'm going to assume that's your shield from life, from stupid exercises, from pain. I got to strip that shield off. There's your movement, okay? So all these little tricks and gimmicks we do, like the toe touch progression that really just frees up those lumbar segments and lets you use your body functionally, and that's not the treatment. I simply proved that you got way better tissue than you thought, but you got some stuff amping up your tone. So when we see the tone in your outer muscles, like your lats and your pecs and your quads and your abs, get high, your hamstrings, we know that the tone in your deep muscles is low. And so when I put you on the ground, you look like a turtle on your back trying to roll around, right? You can't even do a get up on one side, but you do it pretty good on the other side. That's core muscles. Trying to coach that instead of just sort of creating an environment where that can happen, that's the biggest mistake I've ever made, okay? It's more complex than you think. How many clinicians I got in the room? ATCs, PTs, DCs, MDs, whatever. We're supposed to know the difference between diagnosis and prognosis. Diagnosis means this is what I think is your problem. Prognosis is here's how I think it's going to play out. You tell me you got an L4-5 disc in your low back, I have no idea how it's going to play out. Are you type 2 diabetic? Are you overweight? Can you touch your toes? How deep is your breathing? What's your sleep like? Are you hydrated? What's your nutritional awareness like? Oh, by the way, how's your behavioral health? What's your past medical history? Oh, I got a total hip and plates in my foot. That sort of changes things, don't you think? L4-5 disc doesn't tell me a damn thing. I still need to know who it's in, okay? So I wrote 3 editorials for the International Journal of Sports Physical Therapy last year on how we can use screening and tech to basically do this little equation. It's your diagnosis plus your risk factors that tell me you're going to be okay in 3 months, but it's going to take her 6. I don't have anything personally against her. The economy of her situation is she started her investment portfolio with greater physical debt than you did. She's got to repay sleep. She's got to repay better body comp. She's got to repay a blood sugar problem. And she's got to fix her back. You're just a triathlete that was running too much. You just pulled your low back. It's going to be different. People don't frame it like this, so take a shot of that right there or get a picture of it. That'll take you right to that first editorial I wrote. But we all in clinic really have to decide, are we discharging somebody ready to train, or they still got issues? Because most of them still got issues. And that's what that article's about. A bunch of people in the military had pain. They went through physical therapy. Most of them weren't operational ready after they'd been through rehab. Now the rehab problem is a strength coach's problem. First responders, those are our firefighters, police officers in many cases, paramedics. When we look at their musculoskeletal risk factors, the risk of injury, that means all these people doing the same obstacle course, the group that are in red and yellow are going to have more mishaps, more problems, more slips, more falls, more accident, and more pain at the end of the course. Why? Is it because they're overweight or have tight ankles? Yes. Is it because they have poor movement patterns or bad posture? It's all that. So when we look at musculoskeletal risk, we just don't look at how strong you are, how fit you are, what your BMI is. We got to look at how you move, how you breathe, how you recover. 62% of the firehouses that ask us to come in and show them how to train better need rehab, not metabolic packages. That's just the way it is. So I'd rather lead with the truth, because if somebody doesn't like hearing that, I don't have to lie. I just got to find another contract, okay? You can't hide this data anymore. It's becoming public knowledge. People are way less fit than they used to be. You better change your sharp fitness stick and point it in a different direction, because it's not going to work on these people. But there's a lot of untapped business here. Okay, general public. Those are your same clients and patients right there. A little bit worse than the first responders that are taking care of them. D1 athletes, they look a little bit better. Sports weed out bad movement a little bit quicker than fitness or rehab. We accept all comers. Sports doesn't. You don't move well enough, you're out. Or you get hurt, and then you're out. Well, last year when Lee and I were here, we had a bunch of you guys go through an app. You gave yourself a movement test and you answered questions about your sleep, your BMI, your past medical history, your behavioral health, your nutritional awareness. And that's y'all. That's this room. That is Chicago, Providence, and LA, all accumulated from last year. Everybody in these seats. If you weren't here, that is still representative of your group, I promise you, because we got enough numbers. Oh, that's also all of the physical therapists that showed up in Utah to hear me speak last year as well. So the irony is, whether you're wearing your health badge or your fitness badge or your performance badge or your physical education badge or your Pilates badge or your kettlebells badge, you're just as jacked up as the people you're flashing that badge to. And so am I. But if we can see our blind spots, if you can have these talks with yourself, then I don't have to give you a class on how to have these talks with a client. Sometimes I pull myself off the physical therapy floor so a lot of the interns in our clinic can learn to swim on their own. Had a guy stop me in the parking lot. Hadn't been in a clinic in a month. I was downstairs writing some stuff. Greg, I'm talking to the staff up there. My doctor wants me to get a low back fusion. What do you think? I used to be a polite Southern gentleman. I'm the son of a Methodist preacher. You got to watch what you say where we live. But I also knew some facts about this guy. I said, I'd make that decision 30 pounds from now. That was an impolite thing to say in my mind 2 years ago. It was a loving thing to say right now, because he's not going to do well with a fusion. He's got too many risk factors. Oh, type 2 diabetic with sleep apnea. You really going to cut on that person? The surgeon would. Guy's got to pay for a boat. But I wouldn't let you cut on me until I knew my outcomes were best. So he's got the automatic excuse. How do I lose weight if my back hurts? Like, in the kitchen. No, I'm not asking you to do deadlifts. Like, how many soft drinks you drink a day? He said, 2 Dr. Peppers, man. All right, that's the South. You take somebody's soft drink and cigarette away, how are they going to watch NASCAR, right? 6 weeks go by. I'm walking through the clinic. There he is. I'm down 20 pounds. I don't think I want surgery, but I got a confession. I'm like, what? He goes, I'm still drinking Dr. Pepper. I'm like, really? He's like, yep, one on Sunday morning with my grandson. I'm like, don't stop that one. I'm not his physical therapist, all right? But also was as transparent and honest as I could be. Don't make a surgical decision when you're really, really poor risk for the rehab. Do the rehab first. You'll go into surgery better, or you won't need it at all. Gray Cook ain't got to say that. Every one of you had an opportunity to say that last week, and you decided, let's do a few more sets and not uncover that topic. Tell these dumbasses to get a wearable and listen to it. You got to coach their recovery. You can't just coach their stress anymore. Nobody taught them how to live. They woke up on a screen. They started this life on a screen. So, use a screen to engage them. If you want to talk about pain, and you're going to train with me as a strength coach or a physical therapist or a chiropractor, I am going to make you start using 3 maps, okay? Anybody can take 1 map on a trip. You know what a GPS is? It's 3 maps. It's overlaying 3 different things: weather conditions, current traffic, detours, the old map, the satellite map, and the internet map. And that's why GPSs work better than the old map that you used to keep in the glove box of a car. So, let's map functional pain first. Now, believe it or not, many of the things we developed at FMS map all this stuff for you at the same time. But I'm going to break them out and show you how these roads cross at the place where we're going to strike. At the place I'm going to help you out, I'm going to help your client out, I'm going to help my next patient out. Let's talk about functional pain map first. This guy is James Syriacs, and before MRIs, this is the way he would diagnose a muscle tear, a 4-point distribution. Muscles are strong and painless, and therefore they're normal. They're strong and painful and have a minor lesion. They're weak and painful and have a major tear or lesion, or they're weak and painless, and until I know different, I'm going to call that a neurological problem, okay? This is before MRIs. That's brilliant. That's deductive reasoning. That's a guy on his feet making a musculoskeletal decision like an artist. How many people in here know what the SFMA is? It is a functional breakdown of movement that follows his lead. If I can touch my toes and it doesn't hurt, I call that functional and non-painful. If I touch my toes and it hurts, I call it functional and painful. I don't call it dysfunctional. If you hadn't said pain, I would have said that was normal. You covered your range of motion mark, you just didn't do it comfortably, so call it what it is. You have a functional representation of range of motion, but it's painful to do so. What are the other distributions? I can't touch my toes and it hurts, and it doesn't hurt, but I can't touch my toes. That's dysfunctional, non-painful. And a movement screen doesn't just find the movements that hurt people, it finds the movements that you can't do, but it's not because of pain. There's your window of training. Step up and train that, and they never make it to my table, okay? Oh, it hurts when I extend my back. Does this hurt? No. Your balance is for shit. Let's fix your balance. We'll check your low back extension next week. Is that so hard to do? I wouldn't do anything to make their back extension stronger. I don't know it's a weakness problem. But a lot of us, we chase the pain. I want to just map it out and find out which movements hurt and which ones don't. So that dude right there with the mustache was Paul Hughes. He was James Syriac's physical therapist. My lineage is, for 3 years, that guy Paul Hughes beat the living hell out of me as I was trying to become an orthopedic specialist. He would come in after me and always find something on my exams I missed. So where do you think the SFMA and the FMS came from? That guy beating the crap out of me because his standard operating procedure in the exam room left no stone unturned. And when I left working for him, I was flying jets. I was maverick and didn't even know it because I was pulling out problems that people 10 years my senior weren't seeing. I wasn't smarter and I didn't have more reps. I just always did a head-to-toe check on everybody because what they're pointing at is what they want me to work on. But that's what the last 3 people did. And it didn't work. Now, pain is going to be in categories, and I can give you direct trauma to tissue, and we'll have that nociceptive pain. That is tissue disruption, that is harm, that is inflammation. You're going to go through an inflammatory process. Now, we can have radiating pain, pain that sort of goes from one place to another. And you got pain down your leg, most people will say, well, that's sciatica, you got pressure on a nerve root. Well, believe it or not, muscle trigger points can give you referred pain too. And then we got nocioplastic pain. And it doesn't mean it's all in your head. It means that if you've been suffering with pain for more than a year, you've rewired your friggin' brain. And it's called pain behavior. You literally organize your workouts, your activities, and your day and your labor around what hurts and what doesn't. If you've ever avoided a staircase, you know exactly what I'm talking about. Okay? Now, here's the first thing that became controversial when I proposed a movement screen as a young physical therapist and a strength coach. That shit ain't supposed to hurt. But many of you right now know, well, if I did one of those, it would hurt. Well, do you have an answer? Have you run any of the maps? Where are your dysfunctions in your lifestyle? Where are your dysfunctions in your movement? And what's your pain map say? If we run those 3 maps, it doesn't matter if you have pain in one of these movements or not. That's a very frequent thing that people do. What I'm saying is, if you have pain in one of those movements, that is a risk factor telling us that it needs to go away. So I don't know why you have pain in one of those moves. We're going to run 3 different maps. We're not just going to assume that the local anatomy needs to be adjusted or surgery. We still got to map it out. But movement screens, first and foremost, shouldn't hurt. And they do, but we've seen a huge erosion in culture. When we first came out with the movement screen, we had a 20% fail rate due to pain. This is mostly high school kids because the movement screen was basically just an outreach tool for us and the local athletes in Southern Virginia. But we started doing it with pro athletes. We started doing it with military first responder. We've modified it a few times because, I'll be honest with you, my mom's in her 80s. I don't need to see her lunge and her push-up to movement screener. But I still need to see her stand on one foot, turn left and right, touch her toes, and bend backward. I just do. If I were to make a recommendation with less than that, I would be underserving her, and I wouldn't be putting myself in a position to capture some risk factors that may get flared up with her exercise program. So, you got flexion pain with your back. It hurts to forward bend. We always see that more as a disc and nerve thing. You got extension pain, we see that as a joint thing. That's basic 101 spine health, okay? Hurts when you go back, we sort of question your joints and your alignment. Hurts when you go down, we sort of question the integrity of your disc and your nerves, okay? Flexion-oriented pain. Bad lifting mechanics, poor technique, strength training without good supervision, okay? Hyperextension injuries, hyperflexion injuries. Now, we don't just map pain with flexion. The entire SFMA, our medical movement screen that we teach people who diagnose this stuff, is we break out everything else that's supposed to be flexing, okay? You're supposed to be dorsiflexing your ankle a little bit. You're supposed to be flexing your hip a little bit. You're supposed to be flexing your T-spine. Everything's supposed to contribute to forward bending, and a lot of times the rest of the body isn't, so the low back does more. You don't need to get stronger. You don't need deadlifts. You need to figure out how to forward bend without exploiting your low back. So finding the fact that your right hip doesn't flex and getting that out of the way, your back comes right back around by removing that.
Make it sound.
Extension. What's the low-hanging fruit on people who have extension low back pain? You know what the answer? Their hips don't extend. They're using their QL for their glutes. How are they not going to have low back pain? You ever seen a QL? It's not nearly as impressive as a glute. A glute's a big old piece of meat. A QL is literally a Pop-Tart. A QL can never be a glute. But if you don't extend your hips and you need extension, the QL is going to do it. There you go. So, oh, you got extension low back pain, nobody ever checks that hip. We built it right in. You learn the SFMA, I don't let you miss it, because I missed it a few times and I underserved my client. I underserved my patient. I let them be in pain more than they needed to be, and that's my fault, and I had to own it. And you don't just have shitty hard talks with yourself, you build systems that keep you from getting cockier than you deserve to be. And I was pretty cocky as a young physical therapist and strength coach. Because if you don't listen to these signals, that's where you end up. Anybody in this room got one of those in your low back? Fun, isn't it? How about a neck like that? That's my neck. I had that surgery 10 years ago. I went into that surgery with way more risk factors than I need, and that surgery did not make me a bit more comfortable than I was before I had the surgery. But it saved my life and allowed me to start working on it. Surgery don't fix you. Surgery keeps you from getting worse. Somebody who looks at the big picture of you fixes you, okay? So I'm not preaching to you guys. I've walked the walk. I've been on both sides of it. I've rehabbed that neck. I have that neck, okay? Radiating pain. We jump straight to the nerve. Glute minimus radiates down the leg just like sciatic nerve. You've got to have somebody to tease that out. It's not always muscle. It's not always nerve. An intelligent person knows how to tease that out, okay? If you've been in chronic pain, you've had pain for more than a year, it is affecting your behavioral health. We got to unpack this too. If you're talking to somebody about your pain, that's great. But if you're not doing anything about your pain, that's not great, okay? Okay, the second map, self-care map. And the word functional here means good enough. My wife wants 10 hours of sleep. Scientifically speaking, and according to her Oura ring, 7 is good enough. So I will try to give her an extra hour's sleep at any point. But if she's ever hovering around 7, we're not going into dysfunction. She's at 6, I got to move out. So we know where the limits are, right? Functional doesn't mean optimizing, but the funny thing is, if you look at every one of these little categories of your life, these behaviors, the diet person is going to be hyper-focused on calorie intake, energy level, calorie burn, dietary stuff. The sleep guru, all right? Oh, your room's got to be 38 degrees. You need a Tempur-Pedic mattress. You need a HEPA-grade filter. It's got to be cold and dark. You got kids, that shit ain't going to happen.
Yeah, true.
Functional's good enough. So if we can say functional for movement, 20 seconds is good enough balance. Not 20 seconds is not good enough. We've got these hard markers, so now we start setting goals within goals. You know how to get people out of their risk factors so they can meet the big goals they're paying you for. All right, breathing quality, behavioral health, sleep wellness, body comp, nutritional awareness, physical activity, injury history. I can get all that and a self-movement screen in 15 minutes on an app, on the phone. Your next client could show up with these 3 maps unpacked for you. If you choose to screen deeper, good for you. If you choose to take action on that, it's already been published in a refereed journal at the gold standard of the movement screen, and that self-screen is going to pick the same risk factors and exercises as the FMS. The FMS has greater detail, and if you're going to be lifting big weights and playing sports, I would recommend do the gold standard. If you're just doing wellness client, I think this is unbelievable to unpack that. So, how do you get into the business of managing somebody's lifestyle? Well, if you're going to stress them, you better give them some organized recovery. Are they wearing a wearable? If they're not, and they basically flunk their sleep survey, tell them to get a wearable. It's as simple as that. You can coach them better looking at their heart rate variability. Do they have sleep apnea? Are they breathing good? You can look at all of this, okay? So I don't do this when the client's standing in front of me. I'm like, do that on your own. I need to see that number one score right there. And if your clients are below 70 on that scale, you're trying to fix fitness with a wellness problem. Fix wellness and fitness will be easy. They'll be your easiest client in the world. Get rid of the risk factor. So I'm trying to give you guys an in to talk to everybody you're working with about pain and some of these things the way I did that dude in the parking lot. Let's cut to the chase. Your first decision isn't surgery. Your first decision is lowering your risk factors. Let's take some time and do that. This is not an emergency. There are things you can't do, but there were things you couldn't do for 2 years. We didn't worry about it, and now we're rushing, right? So here's how the data comes back. Remember those first responders? Physical activity and sleep. Their physical activity is everything, nothing. Everything, nothing, nothing in between. And look at their sleep. So if this is my group, I'm going to organize their warm-ups and workouts around whatever their movement needs are. But the first thing I'm doing is, do you know how to dump tension before you sleep? Because for firefighters, sometimes it's 3 hours and sometimes it can be 8 hours. Do you know how to dump tension before sleep? Because I can show you that in about 10 minutes. You'll sleep better. Remember, nobody's going to give you the massage, but you can do a few stretches according to your movement screen that would literally dump some trap tone. You go to bed, sleep better. General population, sleep, behavioral health, okay? Depression, anxiety, too much screen time, whatever. Don't know why you're anxious, but if you're not sleeping, then there's a good assumption that if you had about maybe 1 or 2 weeks of good sleep cycles, this thing that's about to drive you crazy doesn't go away. It's just not driving you crazy anymore because you're recovered. D1 athletes, sleep is still getting them, but now it's nutrition. Well, they got Captain Crunch dispensers in the college cafeteria. Never seen unlimited cereal before at home. It's unlimited cereal at college, so you can do that. All right, guys, this is us right here. This is a survey of us. We sit there, we got the same sleep problems they do. We've got injury histories that are poorly managed. Oh, we got the same behavioral health our clients do. Jack? So, when they ping movement health on the survey, that means they flunked a movement pattern. When they ping physical activity on the survey, that means they're not getting enough steps. Those are two different things, okay? If you're not getting 7,000 steps, 7 cups of water, and 7 hours of sleep, it's going to be way harder to lose weight than if you're doing those things. Because we follow 2 groups of people, and the only thing different in their programming and diet was the people who were 7,000 steps, 7 cups of water, 7 hours of sleep, and somebody who argued, well, I'll never get one of those. And you're not going to get the weight loss either. But that's sort of the minimum if we're looking at activity level to make your BMI start to change. Most of us try to come up with a conditioning solution for somebody's pain. Calibration. Get them aware of the moves they got, the moves they don't. Get them to protect themselves from not making it worse. Show them a few correctives to make it better. See how quickly you can remove the correctives and they're still moving good. Now insert the real exercise like single leg deadlifts and say you don't need to go on the straight bar anymore. You're a golfer. Single leg deadlifts actually are better for you than straight bar deadlifts. Ta-da, and you won't hurt your back anymore. Movement health. That's all the movement screen we need to do to line a wellness client up with the FMS. Like I said, I don't need a lunge and a push-up to program people who are doing light workouts, weight loss, and have risk factors. Do you want to chase a soccer ball or run into people? A full movement screen would be nice. A full balance screen would be nice, because you're going to have a concussion. The extra data I got on you before your concussion helps me know when you're fully recovered from your concussion. Now, the way we're doing it when we run the movement map is we literally screen everybody, from the D1 athletes to the high school athletes to the first responders to the general clients. They all go through the app. They go through a movement screen, so they've already heard movement and lifestyle once. Now, if they had pain, I do our medical movement screen. If they did well or have athletic ambition, I do the FMS gold standard. If their function is great, we start squeezing their conditioning to figure out, all right, where do we need to work the most? Power, strength, postural integrity, asymmetry. So that's how we break it down. Once again, that's how we find out what we're going to work on. The painful patterns, believe it or not, I don't do therapy on those. I do treatment on those. The dysfunctional patterns that don't have pain, you are working hard on that. That's the secret in the sauce. The FMS, the scoring criteria. You get a 0 for pain, but you get a 1 for dysfunction. A lot of people don't take those 1s serious. Move those 1s to 2s. Movement quality-wise, you are unburdening the system. You're giving them back their motor control. You're getting the hip mobility, but it's functional. They can use it on their feet. It's not just on the floor when they're rolling out the foam roll. A long, long time ago, maybe before some of you were born, Mike Boyle and I sat in a bar and talked about the joint-by-joint approach. And he said, Cook, spell it out. And I'm like, well, your foot is supposed to be stable. Your ankle's supposed to be mobile. Your knee's supposed to be stable, and your hip's supposed to be mobile. And if you start reversing that, you're going to have problems. So every one of those joints is sort of a layered approach. Now, that's become pretty good, and it's a neat way to look at things. But it really explains that if you're working on the knee and you're not aware of what the ankle and hip can do, then you're not really working on the knee. So it's a way of saying we got to look at the whole body. Now, how many clinicians in here have heard the term regional interdependence? Regional interdependence means you come in, tell me your low back's hurting, okay? But I find you got 2 stiff shoulders, a locked up ankle, and a locked up hip. In my world, I start working on that first. Loosen up your shoulders a little bit, loosen up your ankle a little bit, loosen up your hip a little bit. Do whatever I got to do, soft tissue-wise, to get you just a little bit looser. Recheck what hurts your low back and see, does this have any relationship with the low back pain or not? It doesn't have to. But if 50% of your low back or 50% of your patterns are better just because I loosened you up in the places that don't hurt, then part of my medical record indicates that the burdens you've got elsewhere in your body are a 50% contributing factor to what's going on in your low back. Now, we've known this for years. It's in the science, but most people don't have time to unpack that way. They don't have time to do it, and that's why we've always said, get smooth with a medical movement screen. These things will jump out at you. You don't have to worry about it anymore. It's all included. The pain fleshes out, the dysfunction fleshes out. It's exactly how you're supposed to look at it. First responders, shoulders. Doesn't mean all the shoulders were the ones that caused pain, but more first responders flunked their shoulder movement test than any other movement test. And 50% of the group was in pain. General population, shoulders are showing through. Health and fitness professionals. Now, ask Greg Cook, the orthopedic specialist, what he sees when he looks at that. What was y'all's other biggest problem in lifestyle? Huh? It was sleep. So when I movement screen you, I find a majority of shoulder problems, And when I lifestyle screen you, I find a majority of sleep problems. How's that not a neck problem? Anybody here got stiff neck? I do. I got Wolverine's neck. I got titanium in mine. See where I'm going with this? That wasn't a hard dots to connect. And if I'm wrong, you can prove it. Why? Because I'm wearing a sleep wearable and I'm doing a movement screen. But I'm not wrong. I'm going to make a difference. I just don't know how big it is. I'm not trying to diagnose somebody from doing this stuff. I'm saying look at all the stuff that's left out of the diagnosis that we could be collaborating on together. One of you guys understands what I'm talking about. Most of my patients could see you twice as much as me. I'm there, drop a needle, talk them down off a ledge, help them get off the medication, and tell them to trust you. You chip away at the risk factors, we'll turn more cases than a hospital. And that's the way it is. But we've all got to link up and be part of this, because the same little app that I do bringing patients in the clinic, I give it to them going out of the clinic so they can take that scorecard to their trainer and say, and these are the issues we still got to work on. That's the way that works. So, if you're not running 3 different maps, it's going to be hard to manage these people. It's going to be hard to talk about pain. So let's put some faces on this, okay? I want to train, but I have some issues. Anybody ever heard that phrase before? Okay? I've said that phrase before, all right? So let's look at what we're going with, all right? They're going to answer to all these questions to the point where you're like, man, you need rehab, not exercise, right? That's what it's going to look like. But this guy wants to golf without back pain and improve his energy level. She wants to improve her running times and reduce low back pain, improve her energy. He wants to lose some weight, reduce low back pain, and improve energy. Now, healthcare sees those as the same 3 people. They're going to put them on the same conveyor belt and do the same things with them. Some physical therapy clinics, they'll all get heat, extension exercises, they'll all get the same low back pain sheet. I've been in those clinics. I've been part of those clinics. I don't run those clinics anymore. We like to do it a little bit different. Okay, they all got low back pain, and they're all getting ready to be treated the same way by the world. We're not going to do that, okay? So, what's broken, what's balanced, and what's breaking? That's the way I'm looking at their life, these behaviors, their movements, okay? So, when this guy goes through the app, it pinged his nutrition, it pinged his movement, and it pinged his injury history. There's stuff in his history we got to unpack, okay? For her, we caught her on, wait, she's a runner. How's she got a breathing quality problem? Because she's high threshold and she can't take a deep breath. That's part of her problem. She's training in zone 3, she should be training in zone 2, okay? That's just that. Behavioral health, she's a runner, she's crazy, but it's okay. All runners are crazy. You broke your femur, yeah, but can I go on a run? Sleep. Dude's got sleep apnea. You're not going to get any weight off of him, all right? And it doesn't mean he needs a CPAP. So, pain with movement. This guy, it hurt his low back to touch his toes, and it hurt his low back to squat. It hurt her shoulders to do mobility and rotation. Toe touch hurt that dude. His balance is great, it's in the green. But what movement patterns are dysfunctional in this guy with low back pain? Shoulder mobility and rotation. If his shoulder mobility and rotation were better, you think he'd be wrenching his back, swinging a golf club? No. Let's get more mobility where he needs to give it to and see if we can get him out of back pain. Of course she's not breathing. She doesn't have shoulder mobility or rotation, okay? But she's trying to be a better runner without good balance and without a good squat. I know 2 things right there. Her hips could be more stable and her ankles could be more mobile. That's the problem with most runners. Okay, how about my dude over here? What do we got to work on? Rotation and balance. He's got good shoulder mobility, good squat, toe touch hurts. So the way their program looks is this guy's at metabolic risk already. He's borderline type 2. We're going to talk to him about eating He might want to start checking his blood sugar, but I'm sure we can clean this up with diet, improve his energy level. That's going to reduce his inflammation. That'll help his back. Plus, we're only going to give him moves that he needs to work on. What's he need to work on? Shoulder mobility and rotation. So, no hip hinging, no squatting, work on upper body mobility and rotation. Balance is cool. Don't worry so much about it. Make a lot of sense? Okay, he was getting ready to get the same program as the other two people. He ain't the same. So, what do I want you to do? We did a 5-part series on how to fix every one of these patterns from the ground up. I'm going to hammer his workouts for rotation and upper body. You got 35 exercises in those 2 modules where he's going to think he's getting a complete full body workout. He's not. We're reducing his risk factors in shoulder mobility and rotation. He's going to golf better and his back's going to hurt less because we're taking the play. I'm not trying to strengthen his pain, and I'm not trying just to do the stuff he can. I'm confronting his movement problems. Okay? All right. I already told you she's crazy. She's a runner. She's not going to the gym. However, talking her into zone 2 instead of zone 3, I almost got her there, but I'm going to fix her breathing and I'm going to fix her low back pain. Part of her low back pain was her mileage and poor mobility. I got to control the mileage while I'm working on the mobility. So, I'm not going to do much for upper body rotation. I don't need a hip hinge. I'm going to work on squat and balance. That's one of those movement flows. She doesn't have time to go to the gym, but she can give me 10 minutes before a run and after a run. I'm going to calibrate her body. I'm going to do ankle mobility. I'm going to get her into her deep squat. I'm going to start working on that rib cage, okay? So by giving her an engineered warm-up, it's almost as good as bringing her to the gym and doing correctives, and now she's hitting her run with less tension, and then she's dumping that tension at the end of her run. We're going to get her better too, okay? All right, metabolic. I need this dude in a wearable. Okay? We're just assuming you got sleep apnea. Let's watch what your sleep is like and see if you're recovering. Part of his weight loss is probably poor sleep, not just calorie intake. So, hip hinge hurts his back. Stay away from that. Upper body mobility is good, so you ain't got to work on that. Squat's good, but balance and rotation. He's a perfect candidate for a walking program, but balance and rotation are 2 things that make you walk a lot smoother with a lot less stress on your body. So, he's going to get balance and rotation work. That's his workout. He's going to do a walking program at home, and he's going to wear a wearable at night. All 3 of these clients showed up with low back pain and different goals, okay? But they also had a different cluster of problems. I'm a pretty good coach across there because each one of them got something different, even though they uniquely have low back pain. So listen, anybody in here hurting right now? Come on. All right, is it because of last night or because of the last 4 months? Okay. You got to be honest about that because listen, you got fitness ambition and you also got to heal from whatever broke you. They draw from the same bank account. So once you give it up and quit trying to maintain your fitness and just go ahead and get well, fitness gets a lot easier. So talk to somebody. Don't try to be your own blind spot, okay? If you haven't been through a movement screen, go through one. If you already got pain, find somebody that basically can break you down from head to toe, confront you with your own bullshit. You can fix most of it yourself, but sometimes we need to reset you first, okay? A little dry needling, put a piece of tape, and now start training your shoulders different. You're gonna be fine. So we can improve health data and reduce risk at the same time. I just showed you what to do with 3 clients that I hope never make it to me. They got low back pain, they're pissed off with chiros and PTs, they want you to fix them. I just showed you how to do it, okay? If it ain't working, 20% of the time it's not, send them on over, we'll put them on the table, we'll get them right back to you. 80% of the time, in 1 month, you should have reduced enough risk factors where they're either going to rehab really quick or they don't need me. And that's the partnership that we always wanted FMS to be. It's not just a trainer's company or a clinician's company. It's basically a problem-solving company. And when they finish with physical therapy with me, they're not ready. But insurance ain't going to pay 1 more dime to me. You got to get them ready. And ready's not the next best program on the internet. Ready is, what are their risk factors? What are their debts? What do they got to pay back? Okay? Now, performance enhancement. You're working with people that aren't in pain. You can be reducing their risk data too, okay? So you can work on performance and risk, or you can work on healing and risk, okay? You can't work on healing and performance. It won't work. Healing will always win. Your body is gonna get what it gets, okay? So when you try to improve your health data while trying to maintain or improve your fitness data, it's not gonna work, because you're skipping over the risk factors. The risk factors are how I predict how my patients are gonna do. Nobody ever comes in wondering what's wrong. They already know, I got a neck problem, I got a back problem. How much is it gonna cost? How long is it gonna take? Am I gonna be out of pain? I gotta answer these questions, and I don't have a standard answer like 4 weeks or 6 weeks. All three of those clients right there got 3 different answers of what they should be aware of. You need a wearable. What you shouldn't be doing, I saw the movements that hurt you, and what you should be doing to start reclaiming some ground, reducing risk factors. So, a little bit on my table and a lot on the floor is way better than a lot on my table, okay? That's the whole point. And people bounce back and forth between my table and your floor way too often. They're going to get injured, they're going to get hurt. If they're active individuals, they're more exposed to movement injuries. But if they got risk factors, you're missing something. You got to confront those blind spots. So, start screening people. Use an app, use a movement screen, use somebody else's screen, but use a screen. The problem is, don't just screen because it's popular. If your screens aren't hardwired to a risk factor chip away checklist that you can work on, then they're just marketing. They're not screening anything because they're not changing the program you're doing. My screens actually changed my opinion about what I was going to do because they showed me something that was a blind spot to them and me. So I'm always altering the program within their dysfunction. I'm trying to fix their function while I'm watching their pain reduce. All right? Don't forget to screen them on the way out. If our 2 groups, clinic and training, aren't screening people in and out, we're not getting enough data on what to do for the next generation. But risk factors keep going up. Diabetics keep going up. Obesity keeps going up. Low back pain keeps going up. Why? Because we're trying to fix the thing and not all the things that caused the thing. Okay? All the risk factors. So, when I talk about screening, pick one against your client base. When in doubt, go right to the easiest one and start seeing, are you setting up your program to manage all those risk factors? Because everybody's got an excuse of why they're not screening or why they're not looking at the bigger picture. I just want to be the exercise person. That was 20 years ago. You can't be that person anymore. They're coming to you for everything. They want to feel better, they want to move better, they want to look better. Exercise ain't the answer. Reducing risk factors will use exercises in the right way, okay? So, the thing I've always refused to do is give people packages of what I think everybody's low back ought to do. You shouldn't have a lot of risk factors. And if you do, that's 50% of the thing. Most people skip over the awareness, protection, correction, and go right into a development program strategy because they want to vaccinate you against future low back pain. Not possible, okay? But if we sort of take our blinders off, I got to be aware of the things I don't know about this client and the things they didn't tell me. Screens do that for me. Now I got to make them aware. Some people, I'm going to check their balance test every day. Some people need a wearable. Some people need a hydration monitor. What did they ping in their audit that I'm going to ride? Because I'm going to coach them on one thing in their lifestyle and one thing in their movement life. Then put your program there. Then tailor the cardio to what they need. All right? We got to talk about, and what are you not going to do, because we already know it makes it worse. 9 holes of golf doesn't hurt my back, 18 holes does. So I guess we know what we're not going to do, right? 18 holes of golf. You got to have these talks, because don't assume they're getting it. Correction. If I'm doing a corrective move, think of it as calibrating. I'm not trying to strengthen stabilizers. I'm trying to improve their timing with the movement pattern and the posture that you're asking them to do. They're either aware or they're not. And once they're aware, they work in the background automatically. You don't have to coach them. Development means we don't stop at corrective. We try to take those correctives away. Just like I'd be a great nutritionist if I put you on supplements temporarily, but ultimately I showed you how to eat and cook better. Give me those supplements back. You don't need them. Exercises are supplements. I want to give somebody back paddleboarding. I want to give somebody back adventure running. I want to give somebody back rucking, golf, gymnastics, paddling. I want to give you that back. Not many people are motivated for 3 sets of 10, but I'll use those to get you the thing you want. Okay? So, that prayer's gotten me through a lot of stuff. But the operational word here is courage. All right? If you don't do something different, how are you supposed to get wiser? You don't get wiser by reading books. You get wiser by doing stuff you heard and read about and you feel it's got integrity. You expose yourself transparently to that feedback loop and you have courage. So, if you got a little pain, unpack it better, okay? Don't make the same mistakes I did. If you're working with people in pain, confront it. Confront the risk factors. Have the kind of conversations you saw me stage right now. And I challenge you right now, snap a picture there. Take yourself to a 15-minute wellness screen. I wrote the business of movement on, hey, are you really consuming the product you serve right now? All right? If you're running a movement practice, if you're advising people, if you're putting together workouts, I don't care if it's group or individual, rehab or training, it doesn't matter. If you don't know their wellness coming in, it's going to be hard for you to run predictions and keep them where they need to be moving forward. But what you're really going to learn if you take a functional approach is they're going to turn around and share this app with other people, and it's your business card. You don't have to put FMS on that app. You can put your name on that app because, once again, if you can unpack this stuff and your competitor's not doing it, you're going to get the contracts, you're going to get the teams, you're going to get the individuals, and you're going to get the groups. This is the way it's going. People don't trust healthcare, and wellness is defined by how many risk factors you got or don't got. What's health defined by? Your vital signs. What's fitness defined by? Your test scores. What's wellness defined by? Has anybody ever told you before the word wellness is defined by how many risk factors you have? It's measurable. It's not this cliche, oh, health and wellness. It's a frou-frou word. It's not. Function used to be a frou-frou word, and we added meat to it. Here's a good screen, here's a bad screen. It's proven in the data. Bad movement's a risk factor, okay? It was a theory. In 1997, that was a theory. It's not a theory anymore. 4,000 articles. Movement screening is the best way to get to a movement risk factor that's keeping you from getting them to a fitness, training, or rehab goal. And my last slide is always this one. If you want to watch a movement pro, don't look at the person in the shirt. Look at the person with the flower. They do it right from the beginning. We're the ones that screw it up. Thank you.